Hello, I'm Dr. Gay Carlson, President of the American Academy of Child and Adolescent Psychiatry, with number 33 of my Screenside chats for our AACAP members. I'm going to go off script for a minute. For the past year and a half, we've been doing Screenside chats. Our small team has had the able collaboration of our technical assistant, Wally Trepler. Wally was reliable, accommodating, professional, and fun. 2 weeks ago, he literally dragged himself out of bed to film our previous Screenside chats because he didn't want to let us down. I'm so very sad to say he died from COVID earlier this week. There are so many things we can do because of the quiet, capable support of people who are never seen. We thank our new assistant, Jean Schaefer, for standing in, but we will miss Wally very much and send condolences to his family. So back on script, today we're talking about bipolar disorder in kids. The debate about why manic depression didn't occur in children and adolescents is what got me interested in child psychiatry years ago. Adolescent mania and adolescent onset of manic depressive or bipolar disorder is no longer a controversy. The question of what constitutes mania or bipolar disorder in younger children still is. So I'm talking to Dr. Manpreet Singh, who is Associate Professor of Psychiatry and Behavioral Sciences at Stanford and leads a program aimed to advance understanding and treatment for youth with mood disorders who either have the mood disorders or are at high risk for developing them. She does imaging, pharmacotherapy, and psychotherapy research, the latter including family-focused psychotherapy and mindfulness meditation to reduce family stress and also reduce disease symptoms. At AACAP, she ably co-chairs the research committee and the task force on clinical essentials. So Dr. Singh, there has been, as you know, a resurgence of what I call the bipolar controversy. That is, does pediatric bipolar disorder exist? And if it does, how common is it? So what do you think?
Hi, Dr. Carlson. It's great to be here with you today. Bipolar disorder is one of the most fascinating medical conditions. To start, the diagnosis of bipolar 1 disorder, classic mania, remains, I think, unchanged. But curiously, maybe because it's relatively and stably low in prevalence, there are many who disbelieve that mania even exists, much less fathom that mania can begin in childhood. So I've encountered lately many trainees and clinicians who've never seen mania. And, to know zebras in medicine, I think it's important to see them and contrast them to horses. I've been lucky to be part of specialized programs in pediatric bipolar disorders since my training. So I've had a chance to see more mania than most, but there's still some horses and significantly a lot of horses that come through the clinic. So I spend a lot of time ruling out bipolar disorder than I do ruling it in. Isn't that been your experience too?
It has been. I think you make a really good point that you can read about something and you can look at interviews and so forth and hear about them, but boy, nothing beats seeing them. This is also a little off script, but do you have somebody that you can actually describe to people to sort of bring it alive what you mean by pediatric mania?
Yeah, absolutely. And my colleagues around the country, when we see it and hear that other clinicians have, not unreasonable doubts, I think our general conclusion is that there's some complexity that probably comes into play in the picture that raise doubts. But whenever I evaluate a patient that walks through my door, maybe because, again, I'm in a specialized mood disorders clinic, I take the extra 5 minutes, even if they're presenting with simply depressive symptoms, to not just ask about depression and suicide, but also to be on the ready to ask about mania. And so I ask about dig fast symptoms, I ask about euphoric mania every single time I see a patient. And it's really quite straightforward if you start with the DSM criteria. by asking about a lifetime episode of elevated or euphoric mood or explosive irritability every single day for at least 50% of the day for at least a week. And I've seen most kids who present essentially screen out at that stage because most kids don't have that sustained elevated mood for sustained periods of time during the day or sustained days of the week. You then, if they do say yes, I've experienced that sustained or elevated mood, if it's not in front of you, then you have them describe those secondary cardinal symptoms in addition to dig fast.
Wait. Dig fast is something you and I grew up with. Most of the world don't know dig fast. So say what dig fast is.
Yeah. So, and you want to ask about dig fast, at least I do, in relation to the episode in question. Yeah, I have had, Doc, a time in my life where I've had elevated or just on top of the world, feel like life couldn't be better. Other ways that kids sometimes describe it will be just happy, more happy than usual. Cheerful is a more mature, I think, word older kids tend to use. But the dig fast symptoms, distractibility, motor hyperactivity, I use I for increased goal directed activity, trying to do 5 different things at once, but being very, very hyper focused on doing a lot of specific things. Kids will write rap songs or go on and on about doing something that's artistic or creative, but spend hours on end doing that to the point where they wouldn't even stop to eat, to sleep, to even use the bathroom. They're just kind of on fire. It's a high energy state. G, grandiosity, feeling like they have special powers, can do things that nobody else can do. It's not just an impulsive urge to jump from high heights, but I can fly. I can do things that nobody else can do. Flight of ideas. It's hard to remain focused on the content of the speech because it just jumps from one thing to the other. And it's a fast, qualitatively fast speech. You can't get a word in edgewise or interrupt them. Decreased need for sleep, can go days in a row, not just one random night in isolation, but days in a row without sleeping the usual and needed amount. And of course, teenagers need more sleep. And if they don't get enough sleep during the week, they usually catch up on the weekend. But if they don't show a need for that catch up, that's, of course, an important warning sign. And then T is what I call trouble. Anything that gets you into trouble: sex, drugs, and rock and roll, hypersexuality, increased risk-taking, impulsivity with dangerous consequences for the kid or the people around them. And all of those, any of those 3 symptoms, if there's euphoria, 4 if it's explosive irritability, has to happen within the context of that episode, the episode of at least 50% of the day or more every single day. And
wait. So separate, but with an episode, I think the real fundamental thing is they weren't always like that.
Exactly. So it's a change from baseline behavior.
Yeah. Exactly. So that at least a week bit was something that I think the DSM-3 people came up with to try to encapsulate episodicity, but it doesn't work, Manpreet, because if you have somebody who's been had autism or a severe ADHD or whatever since 2, they can have many of those symptoms, but there's no episode. They didn't used to be something else. And I think what really distinguishes mania is that the person was most of their life not like that, and now, my God, what hit so-and-so? They are just really different.
Right. And I mean, I think autism is a great example because the onset is most frequently in early childhood. And so when I get a lot of kids who've had a history of autism who then hit puberty, all of a sudden show some hypersexual behaviors, and then people wonder, hey, is this now bipolar disorder? Certainly, there's elements of symptoms that are transdiagnostic in psychiatry, and even hypersexuality might be seen in other conditions than mania or bipolar disorder. But there are some more sensitive symptoms and more specific symptoms, and it's not just the symptoms in it of themselves. As we all know, in our training in child psychiatry, we have to think about context, and so it's how these symptoms hang together. And I think there's nothing that beats seeing a patient with classic mania to be able to get a real archetype of what mania looks like across all ages. And I think that the debate seems to be more about this incredulity or doubt, perhaps, that mania as a phenotype could occur younger than a specific age, and I think I would change that incredulity to curiosity. Anyone who has a brain is predisposed, these are brain-based conditions, to a number of biological phenotypes, behavioral phenotypes. What increases a risk for, or what potentially results in a manic episode is something that we should remain curious about and open-minded about. Of course, the diagnosis has its risks and benefits, and I've seen some commentaries that have highlighted the potential harm, right? Whether it's potentially stigmatizing, as some say, of the diagnosis of oppositional defiant disorder, or exposes youth to potential side effects from medications like the DSM-5 popularized DMDD, or disruptive mood dysregulation disorder, which may have had the effect of reducing the diagnosis of bipolar disorder, but didn't reduce the likelihood of second-generation antipsychotic prescriptions.
So let me ask you this, but before you go into that part of it. So you're making a case, and a good one, for the fact that mania, as it exists in adults, occurs at all ages. I mean, you sort of mentioned teenagers before. Teenagers are, to me, off the table. We've known for years it occurs in teenagers. The real question is in younger kids, and part of the difficulty is the younger it goes, the more uncommon it gets. And so therefore it doesn't cross a lot of people's thresholds. Hence, if they haven't seen it, it doesn't exist. There's a certain, feeling about that. But you're not making a case for the fact that it's something different or special in children. Is that correct?
Childhood mania may not be common, and maybe it's reasonable for us to debate its prevalence. But we got to pay attention to signs of continuity across development, because there is research that points to a unified morbid process. In other words, something that started in childhood continues on. And the problem is, again, bipolar disorder is complicated, and does have shifting presentations, or may need to be developmentally contextualized. So the questions that you might ask an adult about manic symptoms might be developmentally contextualized to kids to better understand how that phenotype might present itself in less mature forms. Heart disease is an example of a condition in which science has been really motivated to understand precursors, early stages, and identify opportunities for earlier and less invasive intervention. Asserting that a condition doesn't exist before a certain age, in contrast, would be more like an ostrich strategy. To use your analogy, Gay, it's like analogous to a fire department saying, don't call us until you send pictures of an actual flame. Childhood mania,
but that's
again.
Prodromal. That's prodromal, Manpreet. I think the question, there's two questions. The first question is, and heart disease, good, we can stay with that analogy. Probably myocardial infarctions are pretty rare in children under the age of 12. They can certainly start to have risk factors. Their cholesterol is elevated, they're overweight. There's a whole bunch of things like that put them at risk. And to say, oh, we don't have to worry about you. You're only 10, who cares what happens to you when you're 50? That's a different thing from the kid comes in with palpitations and immediately, you put him in the hospital and you put him in the cardiac intensive care unit because you think he's having a myocardial infarction. So I think the first thing in understanding the bipolar controversy that we need to distinguish is, are we talking about manic depressive illness? And I make that distinction. Kay Jamison and I make that distinction, manic depressive illness, episodes of mania, depression, euthymia. Is that something that it can occur at any age, but it's pretty rare in younger children? Mm-hmm. Or are we saying that there is this chronically irritable, difficult, hyperactive, and many of the symptoms of mania, but not in an episode? So that's the chronic versus acute. And that's common. That is common. That's something that we've all seen. Right.
Right.
And so the question is, is that a special phenotype? The other question that you were starting to get onto is the prodromal symptoms, which is, at what point when you start seeing a stripe here and there, do you say, wait, this may not be a horse, or I don't know. It has to come into full view before I can tell whether it's a horse or not. But I see a little bit of a stripe here. And so it might in turn out to be a zebra after all. But that's different from, it's actually fully bloomed here. So early onset, looks like adult mania, manic depressive illness. You're saying, yes, it can occur at any age, but it's pretty uncommon in younger kids. What do you say about the irritable, chronic, explosive child? Is that a special phenotype, or is that something different?
I think that the research is suggesting, longitudinal follow-up anyway, of those kids who are chronically irritable, that they turn out to have other things, depression, anxiety, other conditions, but most commonly depression, not bipolar disorder. And I'm referencing Ellen Liebenluft's work in the severe mood dysregulation population that she studied for a number of years. And I think that is something we see clinically. I'd like to go back to the issue of chronicity. There are a number of studies that have been done in early onset bipolar disorder that describe that phenotype when it does present younger as being more severe, more associated with higher levels of poor functioning, and has more of a chronic course. So a half a century ago, it was thought that children couldn't have a diagnosis of major depressive disorder. With the acceptance of pediatric onset depression as a diagnosis, we know somewhat more about the origins, the trajectories, and treatments for depression without any diagnostic recognition, a flat out just denial of it. We could not have treated pediatric depression as we do now, nor could we design appropriate research studies. The 30-year doubts of the existence of pediatric depression or American exceptionalism about depression prevalence among youth are virtually non-existent today. Lingering uncertainty about the diagnosis and the trajectory of pediatric bipolar disorder doesn't undermine its utility. Without any recognition of it, research into the evolution of pediatric bipolar disorder, its evolution towards mania, can't be evaluated in a timely fashion without understanding its precursors. And I agree that, those risks and benefits might be fraught in many circumstances because of the concerns that people raise about the burdens of overdiagnosis or treatment, but not accepting the validity of a diagnosis, in my mind, are much higher than risking holding it as a working hypothesis. No one has to commit to necessarily the diagnosis, but being curious about those stripes, I think, does have some not just utility from a longitudinal observation perspective, but it also validates what patients and parents are experiencing. We should just ask them how they are experiencing these symptoms. And most parents and kids that have to contend with early onset mood disorders aren't describing this as a fleeting issue, and even though it may be episodic. So in order for us to prevent this disabling and life-threatening problem from continuing, those early signs need to be evaluated, and we need to be curious about them.
So let me give you the analogy that I have with it, because the longitudinal study that I have learned the most from is a psychosis project that I was part of for many years, and I was responsible for the bipolar end of it. And it started out at the age of 15. It was supposed to be a schizophrenia study, Manpreet. I mean, and they were sort of blindsided by how many people with manic depression and bipolar disorder actually came into the study. So I took care of the kids and I took care of the bipolar people. And indeed, those people who had early onset, adolescent onset for the most part, actually did have a more severe course. They look very much the same as their 25 and 30-year-old counterparts, but there wasn't a huge quibble about the age of onset or mistaking it for something else. So I think the business about earlier onset often has a worse course is true. And I think for schizophrenia, which is the model that we should follow, it is similar. And what I liked about the work, and if you look at the early history of childhood schizophrenia, the way we have childhood mania, childhood schizophrenia, it was a whole boatload of developmental disorders, autism, kids who were left in orphanages. Any kid that was sort of like off the straight and narrow got called childhood schizophrenia. And I remember when I was doing my training, the fights that would go on about, is it autism or is it schizophrenia? Kind of like the early onset bipolar disorder thing we're doing now. And what I liked about what Judy Rappaport and her colleagues at NIMH did is they said, we're going to stick to the rules. This has got to look like adult schizophrenia occurring in kids. It took her like 10 years to come up with 100 kids. It was rare, okay? The other thing that was important about that was she washed in a whole bunch of weird kids that didn't fit any particular, that they didn't have schizophrenia, but we didn't know what they had. And they got called a whole bunch of different names. It is to our detriment that we never did anything about those leftovers, those other kids. But I do think for the bipolar thing, we really would do best to say, we're going to stick to the rules. We can't have, if you're chronically irritable and if you say that your father can beat up, my father can beat up your father, that's a manifestation of grandiosity. I don't think we can make exceptions for kids. We have to follow the rules. But that curiosity that you're talking about, for the kids that don't meet the criteria, those are the ones we have to study. That's what I thought Ellen Liebenluft was doing with her original distinction between severe mood dysregulation disorder, which was chronic, and with the episodic. The problem with the SMD business is it went down its own rabbit hole of not really defining irritability all that well. And so then we got mixed up with the kids who were moody as opposed to the kids who were really volatile and aggressive. And so now we have to disentangle that team. But I think we're better off saying what we don't know and let's try to figure it out, rather than squeezing it into the tent and saying, it's an alternate form of, or an early onset form of, or, really you're being dumb by not calling it that. That's my feeling on the subject, that we call what we can define clearly, and then we take a look at the ones that aren't quite meeting the criteria. So what do you think of that approach?
I don't disagree. Perhaps the definition of pediatric is what's stirring up controversy, and maybe it'd be a good time for us to remind ourselves that the field of pediatrics cares for children from from preconception well into 20s, and thanks to neuroscience, we now appreciate that brain development certainly doesn't stop abruptly at 18. So making arbitrary decisions about early versus very early at 18 or puberty or 12, I think might be a bit of a constraining aspect of how we think about these issues. And I think that, while I appreciate the need for us to be clear in our communication about the phenotype, secular trends globally suggest that the onset of puberty is occurring earlier and earlier in children. And that might contribute to observations of mood disorders in younger populations than previously considered. So then what the question becomes is whether it's conceivable that mania can occur prior to prepubertal onset. If there's no question that mania can occur after puberty, why can't it occur before puberty? And that's the piece there that I think is important to consider, in addition to the fact that many of us as clinicians and researchers have not observed that youth simply grow out of their symptoms, a constellation of symptoms that are forming the long-term result of wait and see. In many ways has resulted in delays in treatment, increased risk for morbidity, mortality, and frankly, illness progression. And it may be perceived by children and families as trivializing the dysfunction and harm that can be associated with that early, very pernicious onset and the impact that it has on development. So I don't disagree that we have work to do to operationalize definitions of early onset bipolar disorder and communicate more clearly. We have to offer better solutions for treatment dilemmas and give hope to families coping with the condition. And we have to work collaboratively. And I don't have any problems with debates. Sometimes actually debates really do advance science. But usually when there's no available answers to fundamental questions. And we don't lack data in pediatric bipolar disorders. So questioning the validity of bipolar disorder in adults who've described these symptoms since they were young doesn't really help them. It doesn't help their offspring because of that early onset pernicious nature. So I think we have to focus our energies to provide those early onset patients with systematic and developmentally sensitive approaches to diagnosis and evidence-based treatments, and to continue iterating towards those solutions that I think most of our both chronic and acute patients need.
So you just had the last word. Something I don't allow everybody, Dr. Singh.
Oh, I'm grateful. Thank you.
Okay, this is clearly a complicated topic, and I think we are inching along to better definitions, better operationalizations, and hopefully better treatments. And so I appreciate the time that you've taken to be with us this morning, and I appreciate the audience's attention. And we'll see you in a couple of weeks. So thank you.
Thank you.
Thank you all very much for tuning in. This is Gay Carlson for AACAP's Screenside Chats.
Provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.